Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctor, at Hetero, we know we are present in multiple therapy areas, including gynecology, obstetrics, orthopedics, pulmonology, and so on and so forth. We expertise in patient benefit related products. We have developed several films so as to produce patient benefit. We market rivastigmine film, we market NSAID films to improve patient compliance, ultimately clinical outcome. Today's webinar on Carbetocin in action focuses on PPH, postpartum hemorrhage. We all know postpartum hemorrhage is an unwelcome guest and expect the unexpected. Hope we don't see the case again. It's better only for discussion case. And to discuss more about this, we have got reputed doctors from Indore, Dr. Anupama Dave and Dr. Vaijayanti Bhoraskar. Madam Dr. Anupama Dave is MS, MRCOG, London, FSCOG, DNB, FICS, FICOG, and MNA, MS. Madam is Professor, Unit Head, Department of Obstetrics Gynecology, MJMNC Indore, Organizing Scientific Committee Chairperson, AICOG 2022, Past Secretary, ISO PARB, Indore Chapter 2017 to 22, Past Secretary, AMPOGS, MP State Association. Madam is active member of Indore Society since last 20 years. Has been a teacher for both UG as well as PG students for last 29 years. Madam has been winner of several awards, including prestigious Foxy Orion Award 2013 for research, Master Trainer for and Nodal Officer for Foxy EMOC training, Master Trainer for IPS. Have several about 64 publications in both national and international journals, and a special interest in high-risk pregnancy, non-descent vaginal hysterectomy. Welcome, Madam. Dr. Vaijayanti Bhoraskar is MBBS MD from BJ Medical College, Pune. Madam has been at Vadia Hospital, prestigious Vadia Hospital, Maternity Home, Mumbai. Madam has worked at South Cleveland Hospital, UK, and is a practicing obstetrician and gynecologist in Indore since 1992. Welcome, Dr. Bhoraskar. A warm welcome to both of you. And I now hand over the session to Dr. Anupama to take the proceedings further. Over to you, Madam.
A very good evening to all of you, and I thank you for your warm introduction. So today we will have a case-based discussion on cases of PPH and how to manage them, and then the role of Carbetocin, which is considered to be a smarter, superior, and safer uterotonic agent. So I myself and Dr. Vaijayanti would be discussing 3 interesting cases and discussing about their management. But let us see a few things about PPH, postpartum hemorrhage. Every minute around the world, 380 women become pregnant. 190 women face unplanned pregnancies or unwanted pregnancies, and 110 women experience pregnancy-related complications. 40 women have unsafe abortion, and 1 woman dies out of this. 1 woman dies of PPH. If you look at the global burden of postpartum hemorrhage, it is estimated that 75,000 women die every year from PPH, and 99% of these deaths occur in limited resource countries. So every 8 minutes, 1 woman dies due to PPH. While the causes of maternal mortality are different, they are multifactorial. Lack of adherence to evidence-based guidelines and delays in care are common reasons for poor maternal health outcomes. If we talk of PPH, it is something we all know. It is defined as total blood loss of 1000 ml or more, along with signs and symptoms of hypovolemia within 24 hours after labor, but it can be secondary PPH, which can occur up to 12 weeks postpartum. The traditional definition is loss of in excess of 500 ml after vaginal birth and 1000 ml of blood after a cesarean section. Although maternal mortality rates have decreased worldwide since the last 4 decades, but PPH still accounts for 10% of all pregnancy-related mortality. Its incidence varies. 1 to 5% is a reasonable estimate, with uterine atony accounting for 70 to 80%. And this is the reason why we need more agents which can help in contracting the uterus, and so that we can prevent PPH. So first, I would like to discuss this first case scenario. Mrs. A, she is a 33-year-old, gravida 4. She'd had previous 3 full-term normal deliveries. She was admitted to our hospital at 40 weeks of pregnancy and was in active labor. Estimated baby weight was 3.6 kg. Only a few important points that her hemoglobin last month was 9.2 gram% and her blood group was AB positive. So she went into labor and delivered a live born baby boy weighing 3.7 kg. Active management of third stage of labor, in which we give 10 units intramuscular oxytocin, was given. Now, after that, when the placenta was delivered, the liver of placenta was examined, it was complete. She started bleeding and there was moderate flow. At that time, she was alert and convalescent. Her vitals were well maintained, pulse 90, BP 120, 74. But after some time, this bleeding increased and PPH was identified. So she had more than 500 ml of blood loss. All measures were taken as per protocol. 40 units of intravenous oxytocin in drip was started. Still bleeding did not stop, so injection carboprost followed by tablet misoprostol 800 micrograms sublingual was given. Even exploration was done to rule out any cervical or vaginal tears. Gradually, after nearly 40 minutes, the uterus regained tone and bleeding stopped. Her vitals were maintained, uterus remained contracted, and then bleeding was totally stopped. But because of this excess acute blood loss, she had to receive 3 units of packed RBC transfusion. So this question is for Dr. Vaijayanti. Was she at a high risk for development of PPH, and what can be done for prevention of PPH in such cases? Ma'am, you're mute. Please.
There are many factors which are responsible for causing PPH, and amongst many factors, in this patient, what we had was she was anemic when she got admitted. She was multipara, gravida 4, and macrosomia. Baby was 3.7 kg, and these are the main factors what she had. So she was anemic, fourth gravida with a large baby. So in this patient probably, so she is obviously on high risk for the PPH. And in such patients, probably apart from active management, we can do some other agents. We could use some other agents instead of oxytocin to prevent PPH in this patient. And I think carbetocin seems to be the right medicine for this patient, because it has been shown to have good role in the prevention of PPH in high-risk patients. So, we know all the various causes that thrombin is responsible, tissue, that is retained products, a tonic uterus, there is a traumatic PPH and other causes. So in this patient, obviously, the tone was less. Apart from carbetocin, there are other care, of course, we have to take about preventing the postpartum hemorrhage. We should usually what we can do is assess the patient early in anemia antenatal cases and try correcting it right since the second trimester itself. So by the time she reaches term, she comes in labor with a good blood transfusion. These days, very good intravenous IV iron is available. So we give it early. The multiple visits are prevented. And of course, the routine management that in high-risk patient, we give large bore cannula in the beginning itself, where we start the IV drip, perineal support to prevent the laceration because it is a good baby. She might need episiotomy also. And then active management, third stage of labor. Over here, we can modify the active management of third stage. And there are various recommendations we can see by WHO that either we can, this is the standard protocol for active management, but then there are other modifications what we can do in cases of high-risk patients, like using combined uterotonics like ergometrin oxytocin, or a combination, we can give tranexamic acid along with oxytocin to prevent PPH. And over here, WHO also recommends carbetocin as a first line treatment to prevent the for active management of labor.
And what is your experience with the use of carbetocin for prevention of PPH?
Yes, we have been using carbetocin fairly well in now. We don't use it in each and every patient, but certainly where we anticipate PPH, like multifetal pregnancy and other over distension of uterus due to various causes. Carbetocin is a good drug. It definitely reduces the need for other medicines because the methergine, we know that it can cause hypertension, loss of nausea and all. So carbetocin is definitely good drug. Other advantage is that as a private practitioner, we visit many hospitals. And many a times we are not able to wait with the patient for 1 or 2 hours. So once we give carbetocin, the action is, it's a long-acting oxytocin-like drug. So sometimes what we see is that little, what we call as a fourth stage of labor, where you see little delayed PPH. And in that case, probably if we have given carbetocin early itself, then it will prevent the later PPH as well. So it is a good drug. And carbetocin is recommended as a single dose, single slow IV drug. It has got a longer shelf life. It is stable at a room temperature. So that is another advantage of carbetocin, that oxytocin efficacy, if the cold chain is not maintained, can be controversial, can be doubtful if the cold chain is not maintained. So probably carbetocin is a good first line medicine in the as a in patients where where we anticipate PPH.
Thank you, ma'am. Now we come to the second case scenario. This is a case which we had encountered in our hospital. Mrs. Rinku, wife of Roshan, 22-year-old Parmi Gavida, 37 weeks, 5 days pregnancy. It was a spontaneous conception. She was referred from District Hospital Barwani with preeclampsia and MCDA twin pregnancy in labor. She was a booked case and had been immunized. The reason of referral was preeclampsia in twins. She gave a history of raised blood pressure since 5 days and was started on tablet low bed. All her other investigations were within normal limits. She was AB positive. Hemoglobin was 11. Now, when she came to us, an urgent bedside obstetric scan was done, which revealed that first baby was cephalic, but the second baby was transverse. Color Doppler was normal. And patient was counseled and explained all possible consequences, like because she had preeclampsia, high risk factors had to be told to her that she can have convulsions and complications may occur. All these were counseled. The risk of PPH was also told to her, and she was advised emergency cesarean section in view of twin pregnancy with second baby transfers. Now, because of preeclampsia, she was given magnesium sulfate. We know that magnesium sulfate itself causes relaxation of uterus, and there are more chances of PPH. Intravenous 500 milligram Tranexa was given. 1 unit of pack cells were arranged, and C-section was scheduled. With all consents, patients were shifted to the OT. Intraoperatively, first baby was delivered by cephalic presentation, second by transverse. Placenta was removed by controlled cord traction. Uterus was atonic, like it did not contract in spite of giving oxytocin. Patient started to bleed profusely and had tachycardia and hypotension. Then, as usual, we started an oxytocin infusion, 40 international units and 500 ml normal saline at the rate of 60 drops per minute, and gave injection Tranexa 1 gram. Still, there was ongoing bleeding. So instead of giving other uterotonics, we thought of giving injection Carbetocin, 100 micrograms IV slowly over 1 minute. And then gradually we saw the abdomen was open and we could see the uterus. The uterus started contracting effectively. So because the uterus contracted, then the abdomen was closed. She was kept in close observation and strict vital charting was done. In the post-operative period, hemoglobin did drop to 9 g/%. So she was given packed RBC. Rest of the post-operative period was uneventful and patient was discharged in a satisfactory condition. So this proves that carbetocin, in spite of giving oxytocin, we can still give carbetocin for PPH management.
So even I came across one patient where we were not expecting PPH. She was a 26-year-old primary gravida, and she had uncomplicated antenatal care. Young girl, and LSCS was done for primary with breech at 38 weeks of pregnancy. On opening, we found that she had a bicornuate uterus. One was a rudimentary horn, and pregnancy was in the other horn. There was all active management was done with giving oxytocin during cesarean section and tranexamic acid as well as a routine. But then she started, at the end of surgery, we found that she had started bleeding, and fairly 300 to 400 ml of blood, the clots were passed. So we removed the clots, massaged the uterus contracted immediately, but then after a few minutes, again it got relaxed and there was a persistent trickling. So in this patient, we did give carbetocin and the bleeding was controlled and patient remained stable after that. So what we can see is that some women, uncomplicated patients, or even after taking all the care, we do come across PPH. If we treat it aggressively at early stage, then further consequences and further complications can be avoided. So at this stage, probably it's a good idea to give carbetocin. And the standard protocol of PPH management that we follow: oxytocin, misoprostol, injectable prostaglandin. Then we give tranexamic acid as well. And if this doesn't work, then we go for a balloon tamponade, followed by surgery as a last resort. So at this stage, early stage, if we give good uterotonics before the condition worsens, it will prevent the further problems. There are various agents that are available for us at this stage is oxytocin, centometrin, that is a combination of oxytocin and methyl ergometrin, oral misoprostol, which we give either sublingual or oral, and then injectable prostaglandin. So of these, each of those medicines do have some side effects. So carbetocin probably is a good option because it has lesser side effect compared to other medicines, and it is quite effective. Definitely as effective or little more effective than oxytocin. Main advantage being stable at room temperature, longer shelf life. It also, that's way, being a stable at room temperature, it avoids the need for cold chain storage. So we can have a predictable response when we give it, and it's provided in a vial. So poor resource countries, probably it is a very useful drug. What is carbetocin? Carbetocin is basically a modified oxytocin. It was created by doing several manufacture. It is an oxytocin analog with a longer duration of action and more stable at the room temperature, heat stable form. So, and then it acts, single dose of carbetocin given 100 microgram after the delivery of baby is sufficient to maintain adequate uterine contraction. It initiates the uterine contraction and the action lasts for about 1 hour. So the action is comparable definitely to oxytocin. And as we have seen that there are various advantages of using carbetocin over oxytocin. I see, as being a private practitioner, the longer duration of action matters a lot because the need for post-operative observation is slightly reduced. After we manage the patient with PPH, quite often we see that the bleeding recurs. Second thing is that when we give oxytocin, it needs quite a lot of monitoring. So given carbetocin, probably the need for monitoring with oxytocin is reduced. Carbetocin is also found to be little better safety profile than oxytocin. It does have similar side effects like oxytocin, has slightly antidiuretic action, some vasopressin-like action with the vasopressin receptors. So fluid overload and hyponatremia can be caused when large amount of fluids are given, large amount of crystalloids are given along with the oxytocin or carbetocin. But since carbetocin is much less potent at vasopressin receptor, it reduces risk of hyponatremia, and it has been reported that up till now no case of hyponatremia has been reported in literature with carbetocin. So this is our experience, what we have shared, that in two patients, one we saw where we used carbetocin as a prophylaxis in high-risk patient for PPH. And secondly, what we used carbetocin was as soon as we diagnosed PPH, to prevent severe PPH in early stage of PPH, use of carbetocin. Of course, like oxytocin, if patient continues to bleed, even after giving carbetocin, we can always give other uterotonics. So is there any evidence of what is the evidence in the literature? We have seen our experiences. So let's see what the literature says about carbetocin.
Yes, evidence. Nowadays, we do practice evidence-based medicine, and whatever we do must be evidence-based, and we must be able to prove that we have done the right thing. If we look at, there are many evidences for the use of carbetocin. It has been very well studied. All these studies are done on the preventive aspect in its way in preventing PPH. The famous WHO champion trial was conducted, in which nearly 30,000 women were enrolled across 10 countries. And in that trial, it was seen that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. The frequencies of the expected adverse outcomes did not differ significantly between the two groups. So it was equivalent. Its efficacy was equivalent to oxytocin. However, carbetocin was seen to decrease the need for other uterotonics versus oxytocin. So once oxytocin is given for active management of third stage of labor, we may require other uterotonics subsequently. But it was seen that these uterotonics were not required when carbetocin was used. Patients treated with carbetocin had less need for additional uterotonics compared to those treated with oxytocin. Then the use of single-dose carbetocin versus a continuous infusion of oxytocin. In this prospective case control study, early hemodynamic effects were assessed, like effect on blood pressure, drop in hemoglobin, uterine tone. All these were monitored 2 hours, 12 hours, and 24 hours after delivery. And it was seen that a single dose of carbetocin was found to be more effective than continuous infusion in preventing PPH. Again, a randomized control trial comparing carbetocin versus oxytocin. This also showed the same result. It was seen that carbetocin was associated with greater reduction in PPH compared to oxytocin. So initially, in a high-risk case, if we give carbetocin, there are less chances that PPH would occur compared to oxytocin. So it was seen to be a good alternative in PPH prevention, especially in high-risk cases. This was another prospective single-center randomized double-blind control trial on 314 patients in the carbetocin group and 310 in the oxytocin group. Blood loss of at least 500 ml within 24 hours was the primary outcome. And so as you can see in this chart, in the carbetocin group, blood loss was less from 2 hours to 24 hours, chances of manual removal of placenta, bleeding after that, prolonged second stage, all those were less when carbetocin was used. Comparison of carbetocin versus oxytocin and the need for other interventions. So compared to oxytocin, prophylactic treatment with carbetocin after an elective cesarean section reduces the need for additional uterotonics by more than 50%. Then efficacy and safety of carbetocin versus symptometrin. Nowadays, we do not use symptometrin, which is a combination of oxytocin, methyl ergometrin. As such, methyl ergometrin is not being used because vasoactive properties, it causes vasoconstriction at different sites, which may cause serious side effects. But it has been seen that Carbetocin is much more effective than symptometrin in the terms of reduction in postpartum blood loss, smaller drop in hemoglobin, and less adverse effects. Now, carbetocin has a comparable safety profile to oxytocin. So these common adverse events like nausea, vomiting, headache, leukocytosis, all these, the percentage was quite less in cases in which carbetocin was used. Similarly, other adverse effects like heart disorders, arrhythmias, palpitations, there were some adverse effects in the oxytocin group, but they were almost nil. Fall in blood pressure, skin rashes, these findings were almost nil when carbetocin was used. So it seems that carbetocin is a promising agent for PPH prevention, and intramuscular admission at a dose of 100 microgram is more effective than oxytocin. Again, similar comparison. It has been more studied in those women who had undergone cesarean section. The risk of PPH was significantly low in the carbetocin group compared to oxytocin group. In many guidelines, in RCOG guidelines, they have recommended routinely carbetocin in cases of cesarean section instead of oxytocin, which is given as IV bolus in cesarean section. Again, comparison with symptometrin, it was found to be efficacious in management of PPH in this particular study. When compared with misoprostol, intravenous carbetocin demonstrated similar efficacy to sublingual misoprostol plus oxytocin infusion for prevention of PPH. So when these two agents, single oxytocin infusion was not sufficient and misoprostol had to be given, instead of that, a single dose of intravenous carbetocin was more effective. These are worldwide guidelines, WHO, SOGC, New Zealand, FIGO, Germany, and FACOG. All of them, nowadays, they recommend carbetocin for prevention of PPH, especially in high-risk cases. Now, if we look at the safety aspects, this is a recent release of guidelines by FIGO. It is a position statement by FIGO in which they've given guidance on the use of heat-stable carbetocin as an alternative to oxytocin in prevention of PPH. In this, they have mentioned that the conditions in which it should not be used, basically the contraindications for labor induction or augmentation during pregnancy or labor, especially in women with cardiovascular disorders, liver or kidney disorders, women with epilepsy, and in women who have known sensitivity to this heat-stable carbetocin or even oxytocin. So in those women, we should not be using carbetocin. However, the use of carbetocin as the first line in the management of PPH is still under trial. So the first line in management of PPH is still initially 5 units IV bolus, followed by 40 units IV infusion. But I had encountered this study. It was a randomized controlled trial in which they had studied carbetocin versus oxytocin in management of atonic PPH after vaginal delivery. In their study, they found that it is a better alternative. So once we have identified PPH, we need to immediately give carbetocin instead of giving oxytocin. So seeing the study, we too did a study 2023-24 in our Department of Obs and Gynae, in which we had studied 130 pregnant women. They were divided into two groups. One group was given carbetocin and the other group was given oxytocin as first line for management of PPH. Both these groups were comparable in regards to age and parity. Majority belonged to age group 20 to 30 years, and most of them were multiparous. The mean amount of blood loss was seen to be significantly less in carbetocin group compared to oxytocin group. Thus, it could be inferred that carbetocin is more effective in controlling blood loss compared to oxytocin. So in 84.6% of cases, blood loss was reduced and there was no need for further uterotonics. And oxytocin group, 64.6% cases, there was a reduced need for other intervention. The findings of the study indicated that carbetocin diminishes the need for additional uterotonics in women with atonic PPH when compared to oxytocin. So we had concluded that carbetocin effectively reduces postpartum blood loss and diminishes the requirement for additional uterotonic agents in women with atonic PPH when compared to oxytocin. But still, many more studies are required to prove its efficacy for it to be evidence-based. So ma'am, now the take-home message.
Yeah. So basically what we see, carbetocin seems to be an ideal and promising agent. And yes, of course, one might question that why not use carbetocin as a first line in majority, in every patient. And as we have seen, few limiting factors, the studies are still ongoing, and everybody hasn't recommended it as a first line treatment in active management. And cost might be a little bit limiting factor. It's slightly expensive compared to oxytocin, but the advantages are manifold. So what we see is it is an excellent agent for prevention of PPH, especially in high risk patients. The advantage, as we said, that it is heat stable up to 30 degrees, which ensures the efficacy of the drug. And it is more effective in managing PPH than oxytocin, with slightly better safety profile, and it often reduces the need for other uterotonic agents, which prevent sort of spares the patient of the side effects of the other uterotonic agents. And then longer duration of action. So probably the main reason for water intoxication or hyponatremia would be fluid retention. And since carbetocin does not require any carrier to be given, we just give single dose slow intravenous, and it is active for 2 hours almost. So obviously the safety profile will be better. So as we said, that whether to use it as first line in all the patients, cost might be one of the factors. And second thing is the guidelines haven't really come. So we'll wait for them to come. I'm sure they'll come soon, like in other countries.
But
So-
whenever there is a doubt, then in those cases, or whenever you have encountered many problems, in those cases, still you can give carbetocin for PPH management.
Right.
So thank you. And
Thank
now,
you.
if there are
Thank you,
questions,
Dr. Dave. Thank you, Dr. Vaijayanti. So one question, interesting question. Can we use this in RH negative patient, carbetocin?
Yes, like our aim to in RH negative patients is minimize the entering fetal blood into the maternal circulation to minimize the sensitization of mother. So like in oxytocin, it can very well be given in RH negative mothers as well.
Another question has just come. If oxytocin is used in second stage, can we use carbetocin for prevention of PPH? Which of course one of the cases did show.
yes, oxytocin is always used for augmentation of labor.
Correct.
Goes in for 5 centimeters dilatation, and then there are no contractions. We do give oxytocin, but it causes uterine contraction. Later on, because carbetocin is a modified form of oxytocin, it can be given.
Thank you very much. Thanks, Dr.
Effect of-
Vaijayanti. Yeah.
Effect of oxytocin will go away after some time. So
Correct.
carbetocin is very well can be given.
But oxytocin can be repeatedly given, and carbetocin is given only once.
Single. Thank you, Dr. Vaijayanti. Thank you, Dr. Anupama. Thanks for your insights on this particular patient. As we all know, PPH is a nightmare. It's better to study in textbooks rather than experience in clinical practice. I was fortunate to have seen only one patient of PPH. And we know prevention is better than cure, and carbetocin will definitely score in preventing PPH because of better clinical profile. Thanks all the doctors who took time to attend this webinar. Gynecology, we know time is very difficult to get. Thank you all of you. Thanks marketing team Hitro for conceptualizing this. Thanks IT team, and last but not the least, thank you sales team for meeting doctors and coordinating. Thank you all of you, and signing off. Thank you.
Thank you.
Thank you. Thanks, madam. It was nice, huh? Very
Yeah.
nice.
How many participants were there?
Priyanka?
Yeah,